Welcome to the 297th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today, I welcome Agnes Arnold Forster and Sam Shotland to discuss pandemic stress and burnout among healthcare workers. Just a reminder, you can usually catch COVID calls live on weekdays at 5:30 p.m. Eastern Time. Just go to the COVID Calls YouTube channel to watch. You can hear COVID calls anytime, recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID calls via Twitter using the handle @USODisaster or @COVID calls. Please do help spread the word and send suggestions for future guests, future topics, and please feel free to suggest yourself as a future guest. As of today, June 23rd, 2021, there are 3,885,531 deaths globally from COVID-19. That's according to the Johns Hopkins University Coronavirus Resource Center. 128,027 deaths from COVID-19 are reported in the UK. The United States is now reporting 602,705 deaths. In India, the death toll has risen to 390,660. That's an official count, although news organizations anticipate that that number is too low. And in Colombia, right now, the death toll is 101,302 lives lost to COVID-19. As a way to bring some humanity to the numbers, I've been reading a life story or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. The headline is Colombia's COVID-19 death toll surpasses 100,000 victims. This was written by Richard Emblin, appeared June 21st, 2021 in the City Paper. Monday marked a tragic milestone for Colombia and the fight against coronavirus. 100,582 victims of the disease, including the day's 648 fatalities and grim single-day record was established. Almost 16 months after the first case of coronavirus was confirmed in the country on March 6th, 2020, few could have imagined the numbers and fatalities surpassing 6 digits and per-day deaths near 600. The daily mortality rate has almost doubled with the third wave of COVID-19 infection and exacerbated as of late April with anti-government protests in the country. After one of the world's longest lockdowns, 167 days before restrictions were eased back in August of 2020, Bogota remains at the epicenter of the pandemic, adding some 11,000 new cases every day in June compared to 400 cases during the same time frame last year. The dramatic surge in new cases and deaths has been accompanied by the economic reactivation of every commercial sector and the lifting of night curfews and the identity card measure Pico y Cédula. The gradual return of trade shows and congresses, as well as reopening of bars and gastropubs with biosecurity protocols, was justified by Mayor Claudia Lopez, based on the serious impact the pandemic has had on households and businesses. It sounds absolutely contradictory from an epidemiological point of view to have 97% occupation of intensive care units and to announce a reopening, stated Lopez on June 7th. But from a social, economic, and political context with deep institutional mistrust, unacceptable poverty, and unemployment that's especially affecting women and young people, it is necessary to reopen, she said. Concerts and in-person sporting events remain excluded from the reopening. Despite ICU occupation in Bogota leveling off at 97% last weekend, or 58 beds available from a total of 2,261, on Saturday, in yet another defiant move, the National Strike Committee was promoting an outdoor concert at the National Park for the following day. The disconnect between Mayor Claudia Lopez and pro-strike events that headline artists who in their own right should be held accountable for propagating contagion among audiences is also an affront to the great majority of Bogota's 8 million residents who respect health measures and the district's last remaining restrictions. Colombia's victims of COVID-19 and passing the 100,000 mark comes days after Brazil registered 500,000 victims among its population of 214 million, compared to 50 million, and which shows that South America continues to be among the most impacted continents with high mortality rates. Surpassed by Peru with 192,202 deaths and close to Argentina's 89,043 deaths, the third wave of infections and deaths in Colombia will continue for at least another month, affirmed the Ministry of Health as a result of the demonstrations, riots, and road blockades of the national strike. President Ivan Duque, during a small religious ceremony inside Casa de Nariño to commemorate the victims of COVID-19, remarked that more than 100,000 deaths from COVID-19 could have been prevented if the country hadn't witnessed agglomerations during the last 6 to 7 weeks, a statement directed at the National Strike Committee. The most lethal wave of the health emergency, according to the Ministry of Health, comes as the country continues its vaccine rollout with 15 million doses administered, of which 4.6 million have been allocated for second doses. On Sunday, the country broke a new record with 317,532 doses given to persons aged 45 or older. The news on Monday that Colombia topped 100,000 victims was accompanied by 23,239 additional cases of infection, raising the national total to almost 4 million. The story was titled, "Colombia's COVID-19 Death Toll Surpasses 100,000 Victims." Okay, I'd like to turn to my conversation for today. Let me introduce you to my guests. Dr. Agnes Arnold Forster is a historian of medicine, work, and the emotions. She's a postdoctoral researcher in the Social Studies of Medicine department at McGill University and has published on the history of cancer, surgery, and the emotions of healthcare labor. Sam Shotland is a historian of medicine, emotions, and capitalism. He's pursuing an MD at the University of Michigan and a PhD in history of science and medicine at Yale University, and has published on the history of children's health and doctors' emotions. Agnes and Sam, thank you so much for joining me on COVID Calls today.
Thanks for having us.
Thank you for having us.
I want to start the way I generally do, just to find out where you're calling from, get a sense of what the pandemic looks like there, perhaps the vaccination situation is there. Agnes, can I start with you on that, please?
Sure. So Montreal has been a slow starter, I would say, but it has got a lot better recently. Vaccinations are going up. I've had my first jab. I've managed to move forward my second. And things like restaurants and bars are slowly opening up. And I think we're down to fewer than 100 cases a day now. So yeah, it's been a long time coming, but it does feel like we are on a kind of positive trajectory, I'd say.
And the situation on campus there, are the things back to something that looks sort of normal, or things still mostly closed down?
Things are still mostly closed down, and there is talk about going back into in-person teaching in the autumn, but there's also going to be a continuation, I think, of blended learning. Some questions about what international students in particular are going to do, because Canada has quite robust border policies about people coming in and quarantining and things like that.
Sam, same question to you, just about where you're calling from and how it's looking there.
Yeah, so I'm calling to you from the bustling metropolis of Ann Arbor, Michigan. But how are things looking over here? Well, as you know, in fall of 2020, Michigan had a pretty big spike in terms of COVID, and now 7 or 8 months later, things are significantly better. The University of Michigan has been executing its vaccine rollout program, and I was fortunate enough to receive the jab. I'm a member of the Pfizer gang as opposed to the Moderna crew, and I had that occur in early January. I was very, very lucky as a medical student. Things are gradually opening up over here. The undergrad, it's not remotely clear if the undergrads even noticed if there was a change, for not to moralize, but things are definitely opening up. I happen to live in a medical fraternity in which there are 26 of us, and our policies have certainly changed, and we are gradually in allowing more people to come into our house, and if vaccinated, unmasked, so that might give you some sense of what it's like on the ground, or at least in the medical area in Ann Arbor.
I think I'm not familiar with the concept of a medical fraternity.
It's bizarre. It's absolutely bizarre. So essentially, it's exactly what it sounds like. I mean, when you have in the 1870s and 80s with the rise of the Greek system within all, you also have this translate to medical schools, and in the 1920s, there were approximately at the University of Michigan, at least, there were about 12. This is a very perhaps don't cite me on this, but there were perhaps about 11 or 12 different medical fraternities, and there were places of camaraderie, of studying. Yes, people were boorish, and I drank lots of alcohol, unlike certain fraternities today. Luckily, at Michigan, at Phi Rho Sigma, where I happen to be calling you from, we are co-ed. I think we're very progressive, and it's perhaps been one of the best experiences I've had, and one of the best decisions I've made during medical school. So, but yes, wow. Medical fraternities are an under-researched chapter for sure in the history of medical education.
That's fascinating. Now, thank you for sharing that. Again, it adds yet one more sort of social space to sort of imagine how infection control was understood and managed. But a particularly interesting, with the questions around the dinner table at the medical fraternity about whether to lift lockdown, that's a serious amount of expertise at the table. If I could just follow up, I've been asking questions to guests who are based in North America where things have been trending the right way. If they wouldn't mind sharing also maybe a strong memory or association of the last 17 months, something that really registers for them what this pandemic period has looked like. And Sam, let me ask you that first.
Mm-hmm. Yeah, it's tough because there's so many memories. Well, I guess I'll go about this as a student. So in March of 2020, I was studying neurology. I was in the midst of neurology, so I was learning about all the different cranial nerves, and we had just returned from spring break, and what I distinctly remember was that there was a tremendous amount of uncertainty. Classmates were joking around. The undergraduates were still out partying. There was a lot of tension, and one of the things in the frat, there eventually half of the frat would leave to go home. And they were sort of running on a bare bones. So, but what I remember was just this existential dread, because none of us were sure, and especially in terms of studying. I mean, of course, studying during everything that happened with George Floyd was impossible. But with the early days of COVID, it was I couldn't focus on subarachnoid hemorrhages to save my life.
Agnes, just thank you for sharing that, Sam. Same question to you, if you don't mind.
Well, I had a slightly unusual, I suppose so many people's experiences are different, but I started, last March, I was living in London in the UK. And so I moved to Canada this March, just gone. And so that was the whole experience in and of itself, kind of trying to cross borders. At this point in time, we had a stack of paperwork like this big in order just to get through the various airports we had to travel through. But definitely I had a sort of similar experience of, I suppose, existential dread at the beginning March last year. I mean, I'm basically a 5-year-old and I love my birthday. And my birthday was on the 19th of March, which is right at the beginning of the pandemic, and when it was all starting to kind of become clear that this was not just any old virus and this was going to have some sort of like fundamental, life-altering impacts. And I think one of the things that was really tricky about those early days that then kind of continued being really tricky. And I say tricky, it's not like, you know, a big drama or anything, but that kind of having to navigate lots of different people's varying perceptions of risk or ideas about what like good behavior or like adhering to rules looks like, especially in the early days when those rules were pretty imprecise, and you know, the UK was very slow to lock down, relatively speaking, and so there's a lot of flex in there, lots of subjectivity in like what we thought we were able to do. And so me and all my friends and family trying to figure out what the right approach was going to be. And so I remember that being particularly tortured and being, you know, particularly stroppy about having to, you know, not do the celebrations that I'd had planned, and then quickly got a sense of perspective, of course. But, you know, it was definitely an emotional time.
Yeah, thank you for taking us back to that. And it certainly resonates with me. I think I've shared this before, but the taking things off the calendar, which I was slow and reluctant to do. And I look back now, I'm like, I had things on the calendar for June that I thought I was going to do, like, and left them on there till April. And there was something going on there that defies epidemiological wisdom. I just couldn't take them off the calendar.
Absolutely. I was very similar. I think I had a trip for work planned to Canada actually last March and last April. And I just was so reluctant to commit to the idea that that was not going to happen. You know, knowing full well it was definitely not going to happen, but just sort of making that sort of emotional next step was particularly tricky.
Well, let's turn a bit to the conversation at hand and the research that you both have been doing, the work that you're bringing to us at this time. It's really an important set of questions and really innovative work, and I'm glad we have time to talk about it. Agnes, I'm going to start with you on this, and it's just a kind of a broad question. So we're talking about stress and burnout and anxiety among healthcare workers, very broadly defined, and we're going to talk about that in terms of physicians, nurses, but also support staff of all different types. And we have the benefit today of also putting that in historical perspective, which is, I think, quite useful. And I've talked to physicians on here about the stress that they've dealt with, as you bring this extra sort of understanding from medical history for us. But I guess my first question, Agnes, to you is just about what you've been watching for during the pandemic, the kinds of anecdotes or stories or data points that may be out there that give you some sort of sense of the scale of the problem. I mean, we can talk about death counts, and we could talk about full ICUs. Those, to me, don't seem to be very sharp instruments to actually understand things like stress and anxiety.
Absolutely. I mean, I think probably the most dramatic statistic that I came across was quite recent. I think it was in May of this year, possibly April. The British Medical Association, which is the British medical kind of union for doctors, they released some survey data that found that about a fifth of UK doctors were considering leaving the profession entirely, partly as a result of this past year, or that this past year had sort of confirmed some pre-existing concerns or experiences or feelings they were having about their work. And I think for me that really tapped into some of the big issues that are so fundamental to our work, my work, Sam's work, which is that this is, you know, not just a sort of story of human cost, right? That this is not just a kind of an important subject of study because it talks about real pain and suffering experienced by people, you know, who are just going about their daily jobs, but also the kind of policy implications and the future planning, the workforce planning for big complex healthcare systems, and how these sorts of emotional turmoils or these sorts of stresses and strains that people are placed under, that they can have this really tangible impact on what we're going to do going forward. We need a robust healthcare system. We need a robust workforce to deliver healthcare. And these sorts of problems have really debilitating effects on how long people's career duration and their commitment to their careers. So yeah, for me, that felt like a particularly kind of poignant moment that summed up a lot of the stuff that I've been kind of thinking about and writing about this past 17 months or so.
Sam, I'm going to bring you in on that. I mean, you're, as a medical student yourself, I mean, it's a deferred gratification, right? It's a long training to then think that a fifth of people in the profession in the UK is a startling number that Agnes sort of pulls out that people might be considering leaving the profession. It's not something you do lightly when you've committed yourself to that career.
Absolutely. Yeah, absolutely. I think it's, especially speaking as an MD PhD student, it's very much the embodiment of delayed gratification. But I think Agnes's anecdote Agnes's statistic is very illustrative, and I hope that the one I'm hoping to provide an anecdote that will hopefully juxtapose well with that. So yeah, for me, I think a lot about the what you could call the martyrdom of healthcare heroes. As much as Agnes and I both dislike the term, especially those who have died by those of whom who have died by suicide. I think of Lorna Breen, who was an emergency physician doctor in New York at Columbia, I believe, who was diagnosed with COVID, and then during the as I understand and then eventually who had no previous history of any emotional distress, only to sort of deteriorate quite rapidly, and eventually died. Was hospitalized, and as I understand it, and then died by suicide. And what I think about is that there are a number of these anecdotes that are circulating right now, and what makes one death particularly exceptional, or what does it take to essentially create a martyr? And it raises because certainly in the 1970s and earlier, you see a statistic that's quite frequently cited, even one that circulates today, in which a full class of doctors will die every year by suicide, or is lost every year by suicide. And what's interesting for me is it raises these questions about the tensions between sort of the individual and the collective, the way Agnes is talking about a little bit, and also about the questions about who's ultimately responsible for the health and well-being of these practitioners, and what does it take to spark a movement? I mean, I think of course of Libby Zion, and the residency reform hours. So yeah, I think for me, it's probably the coverage surrounding Lorna Breen.
Sam, are there metrics within the medical profession? We've got two on the table right now: retirement rate, maybe the acceleration of retirement rate above what you might expect, suicide rate. What are some of the other measures that are out there that may be considered the kind of give, some kind of an aggregate sense of stress in the profession, if those kind of measures exist?
They do. It's a great question, and it's one that Agnes and I have talked a lot about. There are efforts to sort of look at biological variables as well as more social science or psychological variables. So on the one hand, people are attempting to track change. They will do biomedical studies. So for example, there is a study that was put out by someone who I work with here at Michigan. His name is Srijan Sen. He runs something called the Intern Health Study. He's an MD PhD psychiatrist, in which he found that the telomeres of physicians versus non-physicians, the former, their telomeres, so that's the end of a particular chromosome that's associated with aging, shortened by 6 times as much as a non-physician. So certainly there's there are biomedical metrics that people are using, and then certainly and in terms of the more psychological questions, people are administering all kinds of psychological inventories, and the Maslach burnout. I mean, because we're now in a sort of an age of burnout. We're in an age of burnout, or our boomer friends would tell us. And so there are people who are using things like the Maslach index, the Copenhagen index. People are also using metrics associated with satisfaction, with well-being, and I'll briefly say this, and then I'll defer to Agnes on this. But there's very much a reductionistic tendency in trying to talk about this, and on that, Agnes, I defer to you.
Well, I'll just say that absolutely there are plenty of studies that are designed to investigate these sorts of both biological but also kind of social science or psychological markers of distress or stress or strain. And they all have different qualities to them or pros and cons as to how, explanatory or predictive they are. But one of the things that I find as a historian, who's obviously someone very committed to narrative and sort of subjective evidence or people's account of themselves, is that whenever you're turning to science or even kind of the more sciencey social sciences to understand emotions and people's inner lives, I always think there is a degree of limitation and in those sort of studies' ability to really capture what's going on and really capture the problems that people are experiencing. And I think one of the things that's also really interesting about this sort of question of metrics is that there is an entire cottage industry of this research that has been going on since the middle decades of the 20th century. We have a huge amount of data at our disposal about these issues that well predate the kind of current COVID crisis. And, I suppose, again, with my kind of cynical historian hat on, I'm interested in what point do we turn from accumulating information and data to solutions? Because it's very easy to undertake. I mean, it's not very easy. I don't mean to dismiss the kind of intellectual validity of this work, but it's one thing to do a study of a community. It's a whole different thing to think about. Well, what do we do about this problem that has been shown time and time again to be a very real one and one that causes real harm both to individuals and to states and healthcare systems?
I guess my cards are on the table in the sense that I asked you about the sort of personal anecdotes and the kind of data points you look at first before. And I'm glad you brought, into discussion this cottage industry of metrics. And of course, it applies for satisfaction of all kinds of professions. It's a really nice point you make about how you operationalize those. And I guess COVID is going to be, if they're ever going to be operationalized, this is the moment. In disaster studies, there's always this sort of cautionary note where we say, well, if you've been waiting around for the disaster that's going to change the world, you've been waiting for the wrong thing. It's not going to happen. Maybe we'll come to that if COVID is somehow a moment where we get beyond the measures and the studies and actually get to changing practices. But Agnes, just to follow up with you a bit in terms of, for doctors and nurses, let's say pre-COVID, what are some of the tools, strategies, ways that they describe how they cope with patient pain and death? The kinds of things that most of us don't like to think about, much less talk about, but are the daily work in the clinic, in the hospital. How do they cope pre-COVID, non-pandemic?
Yeah, I mean, it's a great question. It's also one that really depends on which member of the healthcare team you're talking about. And one of the things I've written a lot about is surgery, and surgeons have a very different experience of patient death as, say, nurses. Thankfully, we now live in a world where very, very few people die in operating theatres. Some do, but it's very, very uncommon, very unlikely. And then also the way that medicine has become increasingly specialised means that death is in of itself a specialism within medicine. You have people who are experts in palliative care and end-of-life care. And so one of the things that we've seen over the course of the sort of 20th century and into the 21st is a kind of compartmentalization of death within modern healthcare, modern Western healthcare. So you have people who are responsible for a lot of the administering of care and treatment, but then once a patient gets to a certain point, they are sort of transferred over to a different person's responsibility. And there's a great expertise in caring for death and dying. Like palliative care is an expert discipline. And I think one of the strange, almost paradoxical consequences of this, actually very, I think, positive move is that it has meant that when death surprises healthcare professionals who are not necessarily in those sorts of more specialist roles, it can be harder to deal with than if you are, a generalist, or if you're kind of in and amongst death all the time. You acquire a set of emotional skills, both sort of self-preservation skills, but also the skills required to ameliorate other people's suffering, like caring for the dying or their loved ones. And that's one of the things I think that was so difficult about COVID, is that it threw a lot of people who had kind of got out of practice with dealing with death onto the front line of a mass death event. And so that's both, I'm not impugning their abilities as physicians, but it does call into question their emotional capacities, perhaps, in terms of keeping themselves happy and healthy. I mean, happy maybe is too much to ask for, but retain a sense of resilience and kind of robustness in the face of this sort of tragedy. It's something I think about a lot as a historian who's worked in the 19th century as well as today, is that obviously, thankfully today, very few people, it's unusual in Britain and the UK, Britain and the US and Canada, for a lot of people to die from a respiratory infectious disease. And the sort of that sort of progress has sort of meant that whereas doctors in the 19th century were accustomed to this kind of event. And so we're in some ways better equipped to deal with it. Whereas today, with all of our clinical progress, I'm not suggesting we should return to the 19th century
I understand. Yes.
in order to better equip our physicians. But, I do think it's a sort of something that has made this past year particularly difficult for people.
It's interesting, like a lost sort of skill. It's a skill you want to lose, right? I guess to a certain degree, but then you find out all of a sudden that it was a skill or a certain kind of habituation that's hard for physicians who weren't in that space. I mean, I think I've talked about him before, but my neighbor where I used to live in New Jersey, who is an anesthesiologist, but then became an intensivist like everybody else, and all of a sudden he's in the ICU. And so, to go from operating room to ICU, and we didn't talk in depth about it, but I know he saw things that he had not been seeing on his regular scheduled, agenda of surgeries for that day. And I often wondered how that abrupt shift into the ICU world must have had an impact on him. Agnes, I would just a quick follow up on that. I mean, I don't know, maybe we'll come to this also. Is that something that's documentable? That shift, that stress, and sort of like a physician sort of maybe talking about, hey, I went into one type of medicine and I found myself for these 18 months in another space in the hospital. Are they talking about that?
Absolutely, yeah. I mean, one of the things that I did, so again, I've worked in the history of surgery, and so before COVID, I did a lot of oral history interviews with practicing surgeons, retired surgeons, talking to them specifically about their experiences of death. And so I got lots of information, a lot of the kind of ideas about and impressions of how healthcare practitioners cope with death, in the modern world, as it were, comes from that research. And I then did some follow-up research during the pandemic, talking to not necessarily the same surgeons, but some of the same surgeons, but also surgeons in general, who are an interesting category within the kind of whole COVID world, because their very specialized skill set wasn't fantastically useful during COVID, right? They're perfectly competent healthcare professionals in all sorts of ways, but the thing that they've spent their entire lives training for is not the thing that you need when you're dealing with in intensive care. And so it was a really interesting. Some of them had been redeployed, much like your neighbor, to intensive care wards, but some of them had also been kind of left adrift slightly, or were doing very different roles within the hospital, so more like portering roles, or kind of sort of doing things that they felt were not the things they'd been trained for at all. And I think that was not just a kind of distressing new encounter with a death on a new scale, but also kind of troubling to their identity as people who are problem solvers and fixers, and people who are useful in healthcare crises. So I think, and there are great projects being undertaken by other people. There's this great NHS at 70 project in the UK, which is doing these oral history sort of investigations with all sorts of healthcare professionals. So I do think we'll come out of this pandemic with a pretty good, oral history record of these experiences, and how people felt about this shift, both on a kind of practical, intellectual level, but also an emotional one.
Just a reminder that you're listening to COVID Calls, and we're talking about stress and anxiety during the pandemic with healthcare workers today with Agnes Arnold-Forster and Sam Shotland. Sam, I want to come to you and let's bring history into the conversation. I'll hear from both of you on this. I'm going to start with you, but I want to give a quote. You published a piece, a really great article in the Made by History collection that the Washington Post has been doing, and a shout out here to Carly Goodman and her colleagues who've been so wonderful in doing that work. It's just tremendous work. And so let me give a quick quote here to set this up. You write, observers tend to identify the coronavirus ward as an unprecedented battlefield full of unique challenges, and yet it's a product of longstanding issues: insufficient labor protections, excessive working hours, erosion of professional autonomy, and lack of well-funded and institutionalized mental health support for doctors and nurses. You write, unless these deeper problems are addressed, we will continue to see these essential workers suffer even after the pandemic recedes. So now we bring history into the flow of our understanding of COVID-19. Tell us about the American experience of this background that we need so that we can understand what's happening in the ICU.
Yeah, absolutely. So I guess I'll start with a narrative that most historians of medicine know, and then for listeners who aren't as familiar, we'll go from there. In the late 19th century, you see doctors in the United States sort of consolidating and cementing their cultural and intellectual and economic hegemony, and as a result, during the early to mid 20th century period, you see this there's this invocation of the golden age of American medicine, in which this is very much a myth that is promoted today. But it's a great heuristic because people will talk about it as will invoke it in such a way, saying, "Oh, this is when doctors were gods, and there was patient deference, and we're just bacteriology and aseptic and surgery are coming into being, and all kinds of new technological and medical developments are occurring, and then of course in terms of the physician intellectually and affectively, there is this sense of the doctor, the cultural image of the doctor is sort of invincible and heroic, and this is something that gets entrenched more and more as doctors are relying upon this myth to sort of to cement their own expertise and their own cultural hegemony. So it's in this context in sort of post World War II America, which is what I study, that you begin to see a confluence of different factors that begin to illuminate what we could think of as rightfully or wrongfully the origins of the modern physician burnout crisis. So you have many of these cultural elements about vocation and service and what it requires to be a good physician. And at this time, you also see there are these tremendous changes that are occurring in terms of the political economy of American medicine. This is at a moment in which prepaid health insurance is coming into being in the 40s and in the 50s. That's already been being experimented with. You see the rise of Medicare and Medicaid, so the federal government interfering or regulating, depending on who you ask. The AMA was not too happy about it, as you can imagine. And so you have all these economic changes, and that, of course, causes a great amount of distress. It causes a great amount of anxiety and distress on behalf of clinicians, and they start agonizing over the impact of how they're ultimately going to practice medicine. And you see this in terms of discussions about house calls, in terms of clinic time, all kinds of stuff, and it's often expressed in terms of the language of stress and strain, and discontent. You even hear the term the disgruntled pediatrician in the 1960s, but that's a whole other story. So anyway, at this time you have these political economic changes, you have these cultural changes. You also have big shifts in terms of understandings about how doctors are supposed to be socialized. This is a moment in which medical sociology and medical anthropology are sort of coming into their own, and people are trying to understand I mean, of course, like we have the Parsonian sort of sick role, but people are trying to understand how doctors are socialized. So we have the pioneering work of Renee Fox and Becker, and people who are studying the boys in white. And of course, they have conflicting views. But it's at this time that people are trying to make sense of what does it mean to be a doctor in the 1950s at seemingly the height of post-war scientific medicine. And amidst all of this, there are also changes in the way medical. Residencies have already been firmly entrenched after World War II because of you're more likely to get paid if you have specialist training. There are a number of things that are coalescing that begin, and also their anxieties about how doctors and their families are what's the role of the doctor and his family to the larger community, and that prompts all kinds of anxiety. So it's a confluence of all these different things that we begin to see by, and certainly these issues are going on in the early 20th century, as historian and physician Rupi Legha shows in one of her articles. But it's in the post World War II era that we see the manifestation of a lot of the things that we start to begin to think about today.
Agnes, how does this history that Sam has been detailing for us so nicely, how does that look in the UK? Is it similar?
Well, obviously, the UK healthcare system is very different, as it likes to insist as well, from the US.
And the US likes to insist as well that it's not anything like the NHS.
They are each other's bogeymen, as it were. But obviously in the UK since 1948, we've had a nationalised state-funded healthcare system, and most doctors were employees of the state. So obviously that's very different. The other big difference is that healthcare professionals, doctors and nurses, and ancillary healthcare workers in the UK have a much more robust history of unionisation, and so have gone on strike at various points about working conditions and the like. But I just, those sorts of big, major structural differences aside, I think that kind of cultural history of medicine that Sam was describing is a transatlantic one, and is definitely a kind of an Anglophone cultural history of medicine. And so you definitely have similar ideas about vocation, about commitment, about medical hierarchy. You have a rapid transformation across the 19th century of doctors reinventing themselves as socially useful, socially elite members of society. People who are actually, can do things that are useful and cure people and treat people, and, rather than being the kind of quacks and charlatans of the earlier period. And that's that's a huge kind of cultural undertaking, a huge rhetorical undertaking that they pretty much successfully achieved by the 20th century. And so my area of real expertise, especially in this area, is the kind of post-war period. And the post-war period is really marked by some incredibly familiar and recognizable problems. A lot of the issues that we talk about now in healthcare, amongst sort of stress and strain and overwork, are there in the 1950s and 60s. Incredibly long working hours. We're talking by 1976, the average junior doctor in the UK works an 86-hour week, which means you're having people who are working much more than that, as well as people who are working less. And you have repeated sort of contention about the amount of labor that is being demanded of these healthcare professionals, and this is true for nurses as well. You also have the kind of, especially into the 70s and 80s, an increasing managerialism in healthcare, which comes up against a huge amount of opposition by doctors who see this as an encroachment of their kind of traditional autonomy and authority in clinical settings. A lot of disgruntlement about kind of Thatcherite policies, about, sort of quasi-privatization, and an increasing kind of, I suppose, for want of a better word, like neoliberal culture that is increasingly individualized and locates the sort of sources and solution to stress and strain in the individual person rather than in the sort of system more broadly. But one of the things I'd say that is most difficult about being a historian of people who are still very much alive, which, every day I regret that I've made this chronological shift, but is that they have their own narratives of their own histories, right? So, one of the things that's really tricky, I think, about what I do, woe is me, is that doctors can be very allured by a sort of nostalgic, rose-tinted vision of what medicine once was. And so it's very difficult to tease out like change over time. It's very difficult to work out whether, you know, these things that, like, there's a lot of like, oh, it was so great in the good old days when, you know, yes, we worked really long hours, but at least we had autonomy over our days and our schedules and our patients. And so it's quite difficult to tease out, I think, what exactly has gone on in terms of improvement or decline in the kind of quality of working conditions. Mm-hmm. But what we do know is that it's been pretty rough for a long time, and there's been a lot of study of this, you know, these negative working conditions or these poor working conditions. And there's also been very little improvement and very few policy interventions that have actually, I think, made a tangible and positive difference to the emotional experiences of particularly doctors at work.
Mm-hmm. Let's talk about changes we may have seen in medical education, Sam. You know, again, back to this post-war period in the United States or anywhere else that you may be familiar with. Mm-hmm. This, you know, amount of stress and strain, and then how that begins to be reflected in terms of institutional change, doctors and nurses going on strike, whatever sort of forms of dissent there may be. Mm-hmm. How is that addressed in medical education throughout this period? Or is it? I don't know. I mean, one would think that the reality of the workplace then filters back to the preparation that you give students before they enter the profession. But I know in some fields like engineering, that's not always the way it has worked historically. Mm-hmm.
Yeah, no, it's a great question. It's one that I'm banging my head against the wall quite a bit, trying to think through. I'll take a here's my stab at it, I guess. Certainly, in the 1950s and 60s, you as you start to see sort of outsiders beginning to study the sort of non-scientific aspects that influence clinical care in a very sort of very externalist sort of way. You start to see them being, these kinds of experts being integrated into medical education. So in programs like comprehensive care, which was a movement in the 1950s and 60s, trying to sort of it meant many different things to many different people, but in an effort to get at the psychological and social experiences of patients and doctors, and trying to create a new kind of medicine. So you start to see these experts sort of being incorporated and sometimes listened to, most of the time ignored in the beginning, which often prompts quite a few of them to go off in their own directions. But in terms of, so by the time you get to the late 60s and early 70s, there's a lot of discussion about what would eventually be called physician impairment due to drug use, so substance use, as well as sort of emotional impairment. And you start to see people in terms of what we call graduate medical education, as well as undergraduate medical education, so medical school, trying to create programs to monitor this. Often there are some activists who in this period, many of them students, many of them aligned with the what would eventually many of them who were part of the house staff unionization efforts in the late 1960s through the early 1980s, trying to fight for better working conditions, and you find them pushing for more psychological services, more flexibility in terms of work, and the AMA actually partners with them, and in the 70s. But in terms of how it plays out across the educational landscape, there are a number of these activists, and you could say there's a network, but it's not particularly coherent, of people who are trying to bring attention to sort of a lack of due to they're pointing to physician impairments, but on the other hand, they're also pointing to the emotional distress and dehumanization that students are undergoing. And you start to see people beginning to introduce what we think of as sort of proness wellness exercises and psychological counseling, and this faces a lot of opposition, and the history reflects particular institutional specificities. So, for example, at Duke, one of my historical actors, who was a medical anthropologist turned physician, health and well-being activist, had the support of the chair of internal medicine at Duke, and he was very successful. But in a different department at Duke, like I think in radiology, this is in the mid to late 70s. They were not so supportive. So it was very so. And certainly, and then I'll give you an example here at the University of Michigan, and then I'll turn over to Agnes or however we wish to proceed. At the University of Michigan, we actually had a early medical student and resident mental health clinic, because there had been quite a few suicides in the 70s in the medical school and in the dental school, and they created a service, and it was quite bustling. And there were some people who realized that, okay, it's politically expedient to have this. We can't have students. It doesn't look good for the profession to have students dying by suicide. And then only to have by 1985 to have the program sort of vanish after one of the assistant deans who was running it essentially took another job. So it very much reflects the institutional and geographical realities. And certainly there were changes. There were lots of things that were proposed, but some stuck, many didn't.
Just a reminder, you're listening to COVID Calls. I'm talking to Sam Shotland and Agnes Arnold Forster today about stress and burnout and anxiety among healthcare workers. You know, I want to talk a little bit about culture in all of this. We've had our conversation has been talking a lot about, within the confines of these professions and what's happening within the medical schools. And let's broaden it out to talk about, people who are not doctors and never plan to be and hope to avoid the ICU, or avoid the hospital whenever they can. I think everybody probably has. Yeah, right, exactly, which is most of us, we hope. But at the same time, the fascination is real. And it drives the whole industry of medical popular culture. Everybody probably has their shows or their movies that they grew up with that define what they thought what happened in a hospital. I'll date myself. For me, it was MASH, and then Trapper John MD. Now, my mom would talk about Dr. Killdeer. Later generations will have their own that they talk about. So, and I've thought about this in preparation for this conversation, and I thought, what did I, even at that age when I might have been deciding, hey, am I going to go into healthcare work of some type? And I didn't have the science grades to pull it off. But if I'd wanted to, what would I have been thinking? What was the life of a doctor? And a lot of what was in that space was formed by these medical dramas. And one of the defining features of that was the stress and the strain on the physician and their ability to master it and overcome it because of the broader imperative of saving lives. And so that they had to be sacrificed, and they coped with it. I think MASH is quite brilliant at this, because you see in the tent at the end of the day, the different doctors deal with it in different ways. So they do, I think MASH is interesting because they do explore sort of varieties of emotional experience of physicians, but at the end of the day, they get up in the morning and they go back in the tent and they do another 18-hour day. So that's my very cursory sort of introduction to this. And I wonder, Agnes, maybe if you've been thinking about this, writing about this role of the heroic physician and what we do in the broader culture, maybe that we shouldn't, in terms of building that myth.
Absolutely. This is really one of my favorite things to talk about. So I'm very pleased you brought it up. But yeah, absolutely. I mean, what we were talking before about that, like kind of medical culture, that sort of program of self-promotion of doctors, is that it was really taken up with great enthusiasm by the producers of popular culture in the 20th century. And so I am primarily a historian of Britain, and in Britain they had the first basically the first soap opera in Britain was a medical drama, a medical soap opera, also known as a carbolic soap opera, which was called Emergency Ward 10, which was exactly that thing of like heroic self-sacrifice, of sort of an emotional detachment. And the surgeons and the physicians, the male surgeons, physicians, were also sex symbols. And this comes through a lot in my other great hobby, which is medical romance fiction from the post-war period, which was also all about cultivating this, this figure of the doctor as someone who had a certain set of like very attractive, macho, machismo kind of traits, very, the ultimate like granite jawed, the man that you wanted to be with or be. And they were almost always men. And this was also deliberate policy. Like I've looked at letters and written between script writers and producers talking about how they want to cultivate a particularly positive image of healthcare professionals. In the early years of the NHS, this is, without being too cynical, this is propaganda for the medical profession. Benign maybe propaganda, arguably, but it is nonetheless propaganda. And I've also spoken to a lot of doctors who cite their experiences of reading these texts or watching these films or TV programs as one of the reasons why they went into medicine in the first place. So we've got lots of evidence to show that, they do have an impact on people. And they also have an impact on patient perception of healthcare professionals and what patients can expect of their doctors and what they think a good doctor or, good behavior looks like for a physician. And this is important both for like emotional health in terms of like what kind of emotional models you can expect a doctor to have or you think a doctor ought to have in terms of, resilience, robustness, ability to kind of sacrifice your own well-being for the sake of your patients. But it has also had, I think, quite a big impact on the diversity of the profession. So medicine remains a very male-dominated, a very white-dominated profession in both Britain and the US. And there is a lot of evidence, like social science evidence, that one of the reasons that can dissuade or attract medical students into different specialties specifically, or people into medicine generally, is do they think they look like the doctor that they know about or that they can imagine? And do they think they have those sorts of qualities, those personality traits that are supposed to be the ones you need? And that also has its own impact on well-being, right? And about whether you feel included in the profession, whether you feel like your needs and your specific circumstances are being catered to. So I have a vested interest in this because this is, a prime area of research for me. But I also think that this sort of popular culture is like really important and has like real lasting impacts on the professions today.
Agnes, do you think then that will we be expecting a COVID-19 drama or certainly there'll be films? I wonder if, I've been already thinking about this, what kinds of scenes script writers are already sort of imagining. There's so much of what's happened in terms of death in COVID-19 in the United States and in the UK has happened in the it's been a special kind of disaster that most people haven't had access to it. Mm-hmm. And so you do need art as a way to grapple with it, I think. I don't know, as you said, the sort of propagandistic history of the medical drama maybe doesn't give us as much hope as one would like that we can examine it in all of its complexity. But, TV has come a long way, certainly in the last 20 years.
And representations of doctors have come a long way. I mean, something like Grey's Anatomy is, sentimental, but at least it is, it's got colorblind casting. It's got a big range of people who are in different sorts of roles. That's like obviously a good thing. And I do think we'll see a flourishing of COVID-related culture. One of the things that I've thought was quite interesting in the UK is how long-running soap operas, both in hospital settings and outside hospital settings. So we have one called Casualty, which is like a kind of, week night TV program that runs every week. And where they included COVID storylines and where they didn't. And they'd obviously had to kind of navigate that quite carefully, to what extent are you offering people escapism and what extent are you offering people realism? Mm-hmm. A big question.
So we still have a little time left. I think if it's okay with my guests, we might turn to a couple more questions. I've been very generous with time, but okay, great. We still have a couple of things I wanted to try to get to. And part of that is to broaden our understanding of the healthcare workforce. And we've been talking a lot about physicians, but let's talk about the way that your research also brings into focus the experience of nurses, but beyond that as well, the administrators, the cleaning staff, this category of essential worker was deployed throughout the pandemic in the United States. And I appreciate the category, but it's not sufficient, really, to describe a workplace as complicated as a hospital. So, Sam, let me start with you on this. Same kinds of questions. What tools do we have to understand the experience of non-physician healthcare workers, and what kinds of, how do they describe their own experiences? How are we capturing that as historians and policy analysts?
Yeah, it's a fantastic question. It's one that Agnes and I have talked a fair amount about. We're actually editing a special we've just sent in a special collection for the Journal of the History of Medicine and Allied Sciences, which is trying to attend to all healthcare workers' experiences, including non-clerical staff, porters, not as much janitorial stuff, but social workers and nurses, a whole smorgasbord of workers. Of course, I'll save so I'll say that, and then secondly, and then before I get to my main comment, of course, that when we say we have essential workers, essential to whom and expendable at what cost, right? So I think I think for me at least, I think in terms of my work, there's a lot to be said in terms of the kinds of historical questions we want to ask in terms of how physicians relate to non-clerical staff, in terms of kind of the emotional health and well-being that these workers are able to provide, because they relieve an administrative stress. And certainly in the 50s and the 60s, in the 50s and the 60s and the 70s, and really, yes, the 50s and the 60s, you see a lot of physicians talking about practice planning, which is an old theme, of course, in the business of the history of the business of medicine. And you see about the role of the medical secretary and the role of the MA and of others, and essentially suggesting that there is an important role. Now, that's just from the physician perspective. From the perspective of the non-physicians and non-nurses, I would argue that there are many ways to get at this. Some, like historian Gabe Winant, has argued in his book about sort of the rise of the decline of steel and the rise of care, that it's very much the racially marginalized and women who are taking on these roles. And he beautifully illustrates this in his book in terms of trying to give a cultural history. It's really a economic and policy history, but he does get at the social texture of this. So there are many different ways to do this. So I'll give you an example, and then Agnes, I'll turn over to you. So in New York, there is one of the biggest healthcare workers unions is called Local 1199, and in this period, in the late 70s, early 80s, the organization commissioned a musical by prominent composers and writers. Alan Menken being amongst Alan Menken of The Little Mermaid and other Disney musicals amongst them. And they did oral histories, and what's so amazing about this musical is you can read against the grain to get a sense of what it was like to be a a worker. So they're talking about race, they're talking about sex, they're talking about misogyny, they're talking about the grind. There's even a song called Burnout. So I would argue that the way to access this is very much through cultural history, and I'm hoping to explore this in a project at some point. So this is me testing out a few ideas. But yes, I think you can access this through a variety of different ways.
Agnes, just bring you in on this as well, if you want to extend anything Sam's talking about or your own perspective.
Yeah, absolutely. I mean, I think the history of medicine in general, the history of medicine and healthcare has overwhelmingly focused on the experiences of doctors and to a lesser degree nurses, and has really paid very little attention comparatively to all the other members of the healthcare workforce who are, essential to the running and delivery of care and treatment. And this is, true both as a sort of like academic point about academic history, but it's also true about like healthcare policy and sort of healthcare coverage, and these sorts of broad categories of essential worker or key worker, collapse, I think, a lot of variation within those big categories. And because as someone who is, deeply invested in what Sam calls like the moral imperative of looking at the history of physician well-being, you also have to acknowledge that doctors are, have a huge amount of social, intellectual, and financial capital, with very secure, jobs. Whereas most of the people that we're talking about here, porters, administrative staff, cleaners, and people involved in the laundry, at least in the UK, are much more likely to be on insecure contracts, 0-hour contracts, and don't have the same protections that should be owed to physicians and nurses, and are also, as Sam mentioned, more likely to be from migrant communities or people of color or women. And so you have this sort of compounding of sort of vulnerability, I suppose, in the kind of, especially in like the high risk environment of a COVID ward, where who is worthy of protection and who is not, and they deal with very similar issues like emotional turmoil, the stresses and strains of both patient care and workload and all that kind of stuff, but without necessarily the same protections, both kind of legal and employment protections, but also without the same kind of cultural devotion or cultural commendation. And so I think it's really crucial that we include them in our conversations about these issues.
We're almost out of time. I just want to get one more question in, and it comes back to the Washington Post piece that you wrote, and you make the claim there, which I'm very fond of this kind of claim, that the platform for good policy making as we come through and to the other side eventually of this pandemic has to be the historical experience. It can't just be COVID. It has to be the historical experience before COVID and then the life of COVID for healthcare workers. But I'd like to hear from you both about some of the policy interventions that you think are possible. And I'm particularly interested not only in ones that might be ratified by law, but also changes that happen within professional associations, unions, rules of practice. A lot of times that's where you see impactful, in my experience, impactful institutional change before it reaches the law, if it ever does. And so, Agnes, let me bring you in first on this, problem of policy, rules changes, and what we can learn from history to make better policy.
Absolutely. Well, in that article, we argued that what we need are structural interventions rather than individualistic ones. So we need things like limited working hours, more robust in-house expert mental health care and support. We need a different kind of working climate and working culture as well. And I think one of the things that is maybe slightly demoralizing about being a historian of this subject, and which I sort of mentioned at the top of the episode, which is, you look at a long history of mounting evidence of a problem and a long history of repeated attempts to improve the situation. And those attempts don't necessarily have the results that we want to see. And I'm concerned that going forward, we will continue to make those same errors. And I think one of the things that history can be really useful in doing or illuminating is helping us understand, why have these interventions not taken? Why have they not worked? And for me, I think that one of the reasons why there have been repeated attempts in the UK to reduce the number of hours that doctors work, which I think is definitely a good thing. There's some debate over that. I think it's a good thing. I think it's best, best for doctors, best for patients. And there's been lots of attempts to do that, and a lot of attempts, industrial action along those lines. And they have been met with resistance, not just from policymakers and planners and healthcare workforce, organizers, but from healthcare professionals themselves. And I think history can help us understand, why is it that some doctors, and particularly a powerful, section of doctors, are very resistant to this sort of, policy transformation, or these sorts of kind of structural improvements to their working conditions, at the same time as finding their work very difficult and finding, that has real emotional consequences. And I think this goes back again to some of the stuff we were talking about before about these ideas, these incredibly powerful notions of vocation, commitment, self-sacrifice. There's a sort of very pervasive idea, even amongst, the most progressive doctors, that medicine is somehow distinct from other professions, is different from other jobs. And I can see why that happens. I'm not condemning that as a sort of attitude and approach. And I understand the value that is derived from those feelings. But it does mean that acts as a powerful obstacle to the kind of workplace reforms that we might see in other industries that might have really improved the working conditions of other professions. And I think medicine remains very resistant to that because, I'm sure this is going to be kind of quasi-controversial, but if you admit that maybe what you need is, a really good HR system, really great in-house counseling, and a really good, a rota 9 to 5 kind of approach to your job, then maybe that involves slightly relinquishing some of the myths about your profession and some of the really seductive things about being a doctor. And I think that actually we'd all be much better off if we relinquished ourselves from those sort of historical pressures and we're able to rethink healthcare in a way that is, thinks about it as a form of work, as a form of labor that is subject or can be subject to much of the same sort of ameliorations that we've seen in other industries over the course of the 20th century.
Well, thank you for that. That's a really powerful way to frame it. And if that's the trade-off, it's a life and death trade-off for a lot of people in the healthcare space. So this is not small stakes. And maybe I'm not a total pessimist. COVID has sharpened people's sensibilities to the stress and strain on the essential care workforce. So let's hope this is a moment of real change in that regard. Sam, I want to give you the last word on that, and I guess you have a unique vantage point, not only as a scholar but as a physician on this.
Yeah, or one very much in training. Right now, all I can see are bugs and drugs. It's microbiology. So I'm having a great time with that. But no, I think Agnes is absolutely, Agnes's analysis is absolutely right. I would say that in addition to sort of relinquishing these sort of myths of cultural superiority of invincibility, of cultural invincibility, of physician invincibility, I think I would also point to Agnes and I and another colleague of ours, Jacob Moses, are working on a piece right now, in which yes, we argue for why there are all these barriers to structural changes in terms of physician well-being. So as Agnes mentioned, there's the cultural one. Secondly, we would argue that there are a lot of issues associated with sort of medicalizing physician distress. So yes, of course, there are doctors who suffer from substance users, and that can impair their practice, or there are people who are depressed, and that can have an impact. But that doesn't necessarily mean that every single doctor who is depressed makes them a bad physician. And I think the tendency, especially as physicians, this tendency to turn to sort of a biomedical paradigm to explain everything is exceptionally dangerous, and doesn't address the larger structural components of why doctors are facing the stresses that they are. And then thirdly, and then I'll give a specific example of why of how history can be useful. Thirdly, I would point to there's such an emphasis on sort of individualizing responsibility for health, to gesture to a theme that we talked about at the beginning of the episode, in terms of if I light a few candles and I fill out my CBT workbook, or if it's 1978, and I practice a certain kind of force field healing, then things will get better. Or I'll fill out my stress survey, which I have actually a bunch of in my room from the late 70s, as opposed to sort of addressing larger questions about working hours, about staffing, about precisely the things that Agnes mentioned. And then finally, to sort of to make a comment, I think for me at least, the reason I got interested in this work is highly personal. As Agnes suggested, so I actually took some time off of medical school for mental health reasons, and I'm now back, and I'm finishing up my first year of medical school, and I've watched a number of my classmates who've really struggled, and to me, and of course, having now studied the history of this, or studying the history of this, and of what will hopefully be a dissertation project, knock on wood, or I guess, well, I'm not sure what the substance is over in the windowsill, but there is a moral imperative, a moral urgency to this kind of work, in terms of looking out for the well-being of our colleagues, and frankly, for the well-being of individuals who just interact with the healthcare system. If you want to use the word patient, sure, but just people who interact with the healthcare system. I think there's a real moral urgency to heal the healers, as trite as that expression is, but it's true.
You've been listening to COVID Calls, and you can catch COVID Calls most weekdays at 5:30 p.m. Eastern Time. And please join me tomorrow at 5:30 p.m. Eastern Time when I bring Adam Rogers, staff writer for Wired Magazine, back to COVID Calls. Haven't talked to Adam in a while. He has a lot of things on his mind. He's been doing some great writing. We're going to start our conversation tomorrow with discussion about the lab leak theory. So please do join me for that tomorrow at 5:30. And I want to thank my guests, Agnes Arnold Forster and Sam Shotland, for a wide-ranging, in-depth, and to me, really illuminating conversation about stress and strain on the healthcare workforce. Thank you both for the work you're doing and for your public communication about the work, and for taking time today.
Thank
you so much.
Stay healthy, everybody. We'll see you tomorrow, 5:30.